about 6 months early, and I just showed them my proof of moving, and they just allowed it. Yeah.
I would say,
yeah, I mean it's way better than the gym.
Oh, okay.
They're worse, they're absolutely rammed. I went to see Aravamuthan, and that was
It's
quite
extending
small
the
and
screen.
round.
Okay.
And it was very like dark and rambling. I didn't like it.
I swear we can hear everything. Okay, just let you know.
Oh, okay, yeah. Just give us 2 minutes, yeah. Have it like open on the screen.
There is one that's like Dean's. There's no problem. Next one.
I love that like aspect to just relax and wind down. When I was at uni before, they had this gym membership at the uni campus that also included a like CrossFit class twice a week. Yeah, that was good. But that was like in a separate building, so it felt like you had like your gym and normal classes then. And I got so fit from that. Now I could never. If I went to one of those, I'd be on the floor after 5 minutes.
Like, I've not done it. One of my friends got into it, and he said he bought 8 pairs of CrossFit shoes.
Why? Why do you need 8?
No, I didn't. Well, he became a CrossFit trainer for a while, so that's why it was a job.
Yeah, that's really wearing them out.
Yeah.
I think once people get too into it, it's like a cult, but you can just distance yourself a bit. They go to competitions and all sorts, don't they?
Yeah, I know we understood the killer things. You know, the weird.
It's not showing up here.
They're actually really hard work.
They don't.
And the thing that you
Hello, can everybody on the call can hear me?
Yeah, I can hear you fine.
And can you also see if the slides are moving?
Yeah, we can see the slides.
Great. They are moving, aren't they?
It's on the objective screen at the minute.
Yeah. And then now?
It's not moved yet. It might just be a little bit slow.
Now?
Oh, yep. Now it's good. Yep.
Yeah, it's moving. Yeah, it's moving.
Good. Thank you, Sreedharan. Right. Okay. So my name is Dr. Sreedharan. I'm one of the gastroenterologists, especially interested in liver disease. So, well, I struggle with this talk every year because it's all of hepatology in 2 hours. So brace yourselves. Both the presentations are with Anya Roberts. So what we will do is we'll just look at the slides and then I'll tell you what the essential points that you need to remember. And then you can just go home and with a glass of wine on a Friday evening in front of the telly, you can just brush the rest of the talk through. Okay, just raise your hands up anytime. Can you access Vishnu on your thingy? But if somebody raises their hands or something like that, you just.
I cannot bring my mobile.
I can.
Yeah, so if just somebody raises their hands, and that will be useful. So you can just raise your hands or put your hand up sign on the call whenever you have a question. Okay. And vice versa. So I'll actually won't raise my hand, but I'll ask you a question. So be ready for that too. So what we're going to do is for the first hour or just short of an hour or over an hour, we'll talk through alcohol use disorders, alcohol-related liver disease, acute alcoholic hepatitis, alcoholic cirrhosis, and then cirrhosis in general, decompensation, and a little bit about transplant. The transplant bit we would probably be covering in each and every condition that we are actually going to cover in the second half of the talk. So the transplantation in general, you will actually just get an overview of liver transplantation anyway. So the first hour is going to be mostly about alcohol and cirrhosis. So these are your objectives. So you'll basically have an insight about alcohol use disorders, alcohol-related liver disease, all about alcohol-related liver disease indeed, how to approach, how to risk stratify, manage, and also we look at cirrhosis in general, how to identify the risk for cirrhosis or advanced fibrosis in the liver, how to risk stratify those patients in the community or in the hospital, and how do you manage the decompensated liver disease patient. Okay. So this is the burden of alcohol use and alcohol excess. So as you could see there, about 1 in 5 of us adults in this country drink harmfully or hazardously. So they all are defined according to DSM criteria as well as WHO of what you should be drinking or what you will be drinking if you have harmful use, if you have hazardous use, if you have a binge use. So they've all got definitions. So that's beyond the scope of this talk, but that's something that you need to be aware of. And also each and every one of you would need to be aware of what a measure of spirit contains, what a glass of wine contains. And patients say a glass of wine, a glass can be 125, 250, 350 ml glasses. So it all depends. So you need to know when a patient just says occasional alcohol consumption, and we just had a patient on the ward who had started off with occasional alcohol consumption, who came in with a rip-roaring acute alcohol with over 40 units of alcohol consumption per week for 20 years. So that is as easily missed as anything else in the history. Okay. So you could actually see the burden, how much it is costing the NHS. And this is pretty old data. And I didn't even bother in the last few years that I've given this talk. I've never bothered to just check back about the Office of National Statistics of what the latest decades figures are, because that's only go up in one direction. So you actually have 3.5 billion pounds you actually spend in the NHS, and over 20 billion pounds if you look at absences, loss of work, loss of income, accidents, unspent because of that, and discordant family, what have domestic abuse, everything included. So it's well over 20 billion pounds that we are spending in alcohol-related conditions. Okay. And this gives you a worldwide, and it is no different. But one thing we can actually say, causes of liver disease, causes of alcohol-related liver disease, admissions and deaths are on the rise only in the UK compared to all other Northern European and Western European countries. In every other country, the graph is like that. And in the UK, it's like that. And that's the angle of difference. So we are really in trouble as far as liver disease is concerned, and also with regards to alcohol in general it's concerned. And alcohol is the highest cause or commonest cause of young deaths. So that's people less than 60 years of age dying. Alcohol actually superseded most other conditions, apart from heart disease. And even heart disease have fallen now because of the primary PCI and the way we actually deal with coronary artery disease in general. Okay, so it's that bad. So swiftly moving on to what it causes in the liver, because that's the focus today. So you have 3 different stages of alcohol-related liver disease. And initially, it actually manifests with steatosis. And steatosis in itself is probably not a problem, but that's just an indication that something is not right in your liver. And in some patients, the steatosis is associated with inflammation. And inflammation invariably leads to scarring. So that's then fibrosis, and then eventually cirrhosis. And that, in turn, is a risk factor for hepatocellular carcinoma. So you have steatosis, you have steatohepatitis, and then you have fibrosis and cirrhosis and carcinogenesis. Okay? So this happens in the lifetime of patients with alcohol-related liver disease. And we know that some people are actually more prone for alcohol-related liver disease than others. And of what we understand, women are more susceptible, and certain genetic polymorphisms that we carry, which we still quite do not understand, but we do know better than what we did 20 years ago, but we've still not got the hang of it, in order for us to intervene and then say, Vishnu, you can drink all your life, and I don't know your name. James, you better beware. We can't say that yet. But I think eventually we will come down to it. But overall, most important thing is education for everybody, isn't it? Health education and just general awareness for everyone is what really is going to be the game changer, along with legislation, government laws, pricing, and all of that is in it. So it is much more complex for a clinician or just a hepatologist to control alcohol as a problem, as a public health problem in this country. So let's start off with a case, which is the main problem for the clinician. So I've got a 65-year-old lady. This is again a while back. I think she probably might have been about 10 years ago, I think. So she had recently been bereaved, and so she was in a little bit of distress. She was consuming well over about 40 units, but previously she was consuming about 70 units of alcohol a week. And this one, the 40 units of alcohol, she had probably reduced down in the last 3 months. There is always a catch when patients who drink in excess reduce their alcohol intake. The vast majority of patients who come into the hospital reduce it 3 months or 2 months or 1 month before because they are ill. When the liver is unwell, when the liver is ill, when the liver is sick, you can't take alcohol. And often that is the reason why they don't. And they come to you and say, well, I've not been drinking for the last 4 weeks, and that's because your liver is ill. You've not become yellow yet, but your liver was ill, and that's why they don't. Okay, so she was pyrexia, and she was emaciated, obviously. She's not been looking after herself in the last 3 months after the passing of her husband. Her body mass index was 17. She'd had angular stomatitis, bruises, icterus, but there were no stigmata of chronic liver disease, and she had a 4 centimeter enlarged liver on examination. So what would you do next? Well, you'll do some blood tests, won't you? So that's her blood test. Okay, can you all see them? So what are the striking features of that blood test for me? So you just take turns. Just give me one each.
Very high gamma GT.
Yeah, okay. And that, what does it indicate?
Normally alcoholic.
So I wouldn't say alcoholic, alcohol intake. So if somebody has got alcoholic liver disease and you are seeing them in clinic, one of the simplest tools they can see is their gamma GT is downtrending. And if they say they're not drinking that much, you would buy that. And if it is on the opposite direction, you're not so sure. Okay, so recalcitrant alcohol intake, somebody who's been abstaining, I'm actually wanting to put them on a transplant list or something like that. And then if that goes in a different direction, then you need to be aware of it or beware of such a situation. So, but is that very clinically significant for me here? I've got that from the history. Tell me something that is interesting me now.
The AST is high.
Bilirubin is high.
Yeah, obviously, so I'm worried. So her bilirubin is high, that's fine. You said something about the ALT.
Oh, sorry, the AST is higher than the ALT.
Absolutely, that's what I'm interested in. And the most important thing that you need to, if anything that you take home from here today, as far as alcohol is concerned, look at the AST and ALT numbers. They've never been more than 500 on that chart. And that is a feature of alcohol, acute alcoholic hepatitis. So however severe the hepatitis is, the transaminases never go beyond 500. If the transaminases go beyond 500, you need to be thinking about another cause, not alcohol. And often you get patients with very high AST, ALT, and you get a referral, acute alcohol. No, you look for something else. Okay, but in this case, it was 400-ish. I would take that. And then the AST is more than ALT. And often it can be more than twice the ALT. Yeah, so can anybody tell me why AST is more raised than ALT in alcohol-related liver disease? There are a few reasons. So one is it's mitochondrial damage, and there is mitochondrial ALT, mitochondrial AST, cytosolic AST, cytosolic ALT, all of them have different half-lives. And when you actually have excessive mitochondrial damage, the AST tends to be higher in the serum rather than the ALT. And also, patients with alcohol excess do have a deficiency in vitamin B6. So pyridoxal phosphate is one of the cofactors for the synthesis of ALT. And because they are deficient in pyridoxal phosphate, they have more AST than ALT. Okay, so that's right. Okay, so they've got twice the AST or more than ALT anyway. Anything else that worries you or concerns you or interests you?
Hyponatremia.
Yeah, the bad sign. So somebody who has actually not got chronic liver disease and they come in with hyponatremia, any dyselectrolytemia is a worry, particularly hyponatremia. Okay, there is chronic liver disease in itself has actually got an inbuilt adrenal insufficiency. So this is probably not that, but it might be just dyselectrolytemia because of various other things that's happening and that she's quite sick. Okay, the other thing I'm interested in is in the CRP that is high. So why should she have that? So you obviously worry about an infection, but so you would probably do an infection screen and things like that. And what is white cell count likely to be? What is a neutrophils likely to be? Particularly in acute ALCAP, you will have a neutrophilia. Okay, so the features of acute ALCAP will be you would have a neutrophilia, you would have hyperbilirubinemia, you would have an AST-ALT ratio at least 1.5 or more, you would have a temperature, and you can have raised inflammatory markers. And the AST and ALT will never go beyond 500. That's the telltale feature of acute ALCAP. But in some patients who have had decompensated liver, you might not mount all of these responses, and the only thing that would actually tell you that they have an acute ALCAP is white cell count, the inflammatory marker, and the bilirubin. And obviously, she's going to have some deranged clotting and everything that's part of the liver dysfunction. Okay, so you can actually see here, so when she came in, so she does have a neutrophilia, and then she's got her INR, which is also raised. Okay, so that's probably what it is. Okay, so what actually causes acute ALCAP? So there are three mechanisms. So one is your alcohol and its metabolites, particularly acetaldehyde, and they are toxic to the liver cells. They actually stimulate the Kupffer cells, they release the cytokines, tumor necrosis factor alpha, IL-12, and various other cytokines, which then basically go and directly damage the liver tissue. And they can also cause apoptosis of the hepatocytes. And they cause mitochondrial injury, they cause oxidation injury, and all of that will actually cause probably not massive, but sometimes submassive necrosis of the liver, to start with. Okay. And then the repair mechanisms start, and then you have various factors intervening, and a proportion of those patients will actually go on to develop scarring, and we'll see in a minute what are the mediators of scarring in these patients. So there are two different parts the liver takes. It goes into the acute phase, and also it can actually go on and develop chronic scarring and chronic liver disease because of the alcohol. So you need to have some tools to assess these patients when they are acutely ill. So how do we do that? So first we need to confirm the diagnosis, which you have just read, and you don't need a liver biopsy in all of these patients to do that. If you are not sure whether this is alcohol, which we had a recent situation where somebody had taken a drug which can also cause liver toxicity, somebody who has actually had underlying fatty liver disease because of the diabetes, metabolic syndrome, and things like that, and you're not sure. So that is the only time you probably want to do a liver biopsy, or something seronegative autoimmune disease. All of those things might actually want you to do a liver biopsy, but otherwise, you pretty much you can actually base your history and your biochemical findings to make a diagnosis, a swift diagnosis of alcohol-related liver disease. And then you need to risk stratify them. So what are the tools that we can actually use? In turn, you also need to see how dependent they are, what are their withdrawal features, because they can present all in one. So all of that can happen in the same situation. Somebody who can actually, you might not know whether they are encephalopathic or they are withdrawing. So it can be quite a challenge at times, because whatever you're doing as a treatment for either of those can be counterproductive in the opposite spectrum. So you need to be very clear about that. So those are the assessment tools that you use, particularly for the severity of alcoholic liver disease, and also particularly for the dependence and the withdrawal risk of these patients. Okay, the management is largely supportive. So you correct the dyselectrolytemia, you give them fluid replacement, you focus on their nutrition, you give them 35 to 40 kilocalories per kilogram per day and about 1.5 grams of protein per kilogram per day. And also you get the nutritionists involved and manage their phosphate, manage their magnesium. All of these are likely to be deficient, and also their hematinics. So all of those need to be focused on right at the beginning. And often, as we always say, thiamine is a very important thing to do. And when you actually give Tabronex as an injection, you just don't give thiamine. You actually give thiamine and a host of other vitamin B, as well as vitamin C, and a little bit of sugar, all of it with the pair of Tabronex that you're giving in, and that needs to go in right on day one. Okay. So with specific management about steroids and pentoxifylline. Pentoxifylline is done and dusted. It basically was used because it was an antioxidant. So it prevents oxidation type injury. But we've actually seen that that's not going to help in many trials. Whereas the steroids, there have been numerous trials which have been done in alcohol-related liver disease. And some of them have shown benefit, some of them haven't. And we'll just come closer to the details of that in a minute. So the commonest tools that we have used, like from Sheila Sherlock, Dame Sheila Sherlock was the mother of hepatology, the queen of hepatology, whatever you call it, not just in the country, in the whole world. And so the Madry's dysfunction index was actually in vogue when I was training to be a gastroenterologist. And then we moved on with newer scores, the Glasgow alcoholic hepatitis score, and the Lale model, which is based on response to treatment for patients with acute alcoholic hepatitis on steroids. So those are the commonest ones that we use. So if we did use DF index, which basically all of these will use a combination of your liver synthetic function, i.e. bilirubin, albumin, your creatinine, and just a combination of those things. Okay. So if you use them and you find them a higher risk, so a DF of more than 32, a Glasgow score of more than 9, then you think they are actually going to have a poor prognosis. So you need to intervene with some sort of intervention. And the only thing that we have actually proven that can help is steroids. So you stick them on either 30 milligrams or 40 milligrams of prednisolone, of course, being mindful of the complication of infection and all the problems that you're going to create with the high dose steroids in an already unwell patient. So you need to be explaining that very, very carefully to the patient and the family before we actually embark on such things. And you should have excluded some infection beforehand rather than making that worse. So it can be quite a tricky situation. And technically, in a month, we would probably have at least about 3 or 4 patients with acute ALCAP of varying severity on the ward. So it can be quite a challenge. So when you start treating them with steroids, then you basically apply the Lale model. I do not know if you're actually seeing it very well on there. So again, it uses your bilirubin, your albumin, your creatinine, your prothrombin time, but after day 7 of treatment. But a rule of thumb one can use, you don't need to use the model, but it's a validated model. So if you start somebody on steroids and their bilirubin is 500 when you start them on, if you do not see a 25% drop in their bilirubin levels by week 1 or 5 to 7 days, then you know they're not going to benefit from that. So you can, spare them from the complications of long-term steroid treatment. And the traditional conventional dosage will be 30 milligrams of prednisolone for 28 days. That's a big dose for a long period of time. And there are modified dosing regimes which are not as well studied or as well validated. You can actually start off at 40, 30, 20, 10 in 4 weeks and then stop. But that's not validated that much. But more and more clinicians are going towards that kind of a modified regime. And sometimes you can use N-acetylcysteine as well as to start with, particularly the patient is in profound liver failure with raised INR, very high bilirubin, renal damage and all of that. So you can actually give them NAC. Again, it's basically reducing the oxidation injury that's happening in the liver. So if you use the Lale model, if you actually calculate the score, and if it is more than 0.45, you know that patient has a 1 in 4 chance of living or leaving the hospital. It's as bad. And so if you do have somebody who's actually got a little model of 0.45, then you have a decision to make. And unfortunately, a lot of these patients won't be a candidate for an urgent transplant. They might not even be fit, let alone we do not know what their dependency is, what their heart is doing because of the alcohol and all of that. So they might be very tricky, poor candidates for even ITU in your local hospital, let alone having a liver transplant. Okay? But for those patients who are responding, then you carry on with them the treatment, and that is probably the severity based on the scores. So you can actually see the Kaplan-Meier curve dipping in the ones that don't live and the ones that live. So if you are beyond a certain score, then you know that is going to be the mortality rate. Okay? And sometimes it is very difficult for us to explain to the patient who's attending for the first time, to actually tell them that they might not leave the hospital. In a 40-year-old, in a 35-year-old, in a 50-year-old, which is quite a sad thing. Okay, so this gives you the algorithm of how we treat them. That uses the little model, and how you continue the patients on the steroids if they don't hit that 0.45 mark at day 7. And 0.45, then you need to have some discussion. And there are some patients, because we do now transplant patients with acute alcoholic hepatitis, some transplant units do, and some are more receptive than others. Luckily, our transplant unit is a very receptive unit in Cambridge, and we can have an open discussion, and we have a weekly kind of cirrhosis MDM and things like that for the whole region, and we can just, discuss them on a Tuesday lunchtime, and then they will tell us, if they would be interested. And there have been patients who have been transferred across, stayed there in the hospital for 2 months, and then got transplanted. So it's a sticky wicket.
This is regardless of how long they've been abstinent from alcohol?
Yes, and that is the contentious bit. So when I was training as hepatologist in the liver transplant unit in Leeds, we didn't transplant them, we didn't take them. And the 3 months is basically what we're trying to establish is the patients are able to abstain from alcohol even after the transplant. But more importantly, we know that patients who have been drinking up until the hospital admission had done poorly post-transplant than the ones that hadn't. And that is to do with the regeneration of the liver, even though it is scarred and inflamed and necrosed and all of that. What happens is within a matter of days, within a matter of weeks, the liver starts regenerating. And if you're abstaining for a prolonged period of time, it can actually regenerate up to 3 to 6 months. And I've had a patient who's tried recompensating for 12 months, and then he came off the list, and then he's still off the list, 10 years down the line. So you need to give the benefit of doubt because transplant surgery is not a joke. It takes a toll on the body, and you have to be on lifelong immunosuppression, and you might have other things which you might precipitate because of that, all of that, and you might have to come through the surgery in the first place, and you'll never get out following transplant. So that was what the 3-month rule was. All of us, or most clinicians, think, and that is imparted on patients. It's a very valid question. That's imparted on the patient, saying that you've not stopped for 3 months, you're not getting a new liver. But that is still the case, but for highly selected patients who might actually get that. So I do not know if you both knew Mrs. Guest, who was on side room 4 and who got discharged yesterday, and who came with a bilirubin of 500.
Yes, yes.
Yeah, she would have been a candidate that I would have sold it to the transplant unit like that. I mean, she's a working woman, mother of 4 children, and she just had a habit of drinking 4 bottles of wine a week. And she had done that all her life, but she's a perfectly sensible woman. And I knew that she is somebody who's not going to hit the bottles again. But and that is the first time I'm seeing her on MAU. That was the first time I saw her. But you can actually say, well, what is the background? And then you might be able to sell that out. But that you can actually count in a hand or 2. So that's always going to be an issue. The vast majority, you're right, won't get transplanted, won't go to the ICU. And they would have a respect form, and we would say active medical treatment on the ward. And either they, miraculously survive, and they do, or they get an infection or they get renal failure or then languish and then they die. Okay.
There's also a question if someone's raised their hand.
Yeah. So, yeah, who's that?
Aravamuthan.
Oh, hi, Dr. Sri.
Yeah.
Yeah, it's just a question about the steroids. Why do some patients respond to the steroids and some don't? Do we know much about that?
Yeah, it is an anti-inflammatory, isn't it?
Yeah.
So it is a potent anti-inflammatory agent. And so if you look at the main action of steroids in whatever condition that we treat them with, basically steroids stop the activation of T cells. So the T4 cells and the Th17 cells. And so when it is actually combined with an immunosuppressant, so they have a two-stage action on the helper cells, the CD4 cells, the T4 cells. And all of your cytokines and predominantly anti-TNFs would actually go through that pathway. So if you stop the T cells from being activated, then you stop the cytokines from being released and causing damage to any organ, any cell, any system in your body. So I can see the next question coming is then why don't we use anti-TNF itself? Which we have to horrendous results. And so that's where we don't quite know certain things that we think we know. And we still do not know. In all of the inflammatory conditions that we are using, we are just shooting the mediators like we are doing in a video, in a video game when they come. That's all we're doing. We do not know where they are coming, where they are going, why that's starting there, why that's going there, why it's not coming here. We don't know. So all we are doing is mopping up with the various agents, and we are so proud about that. We have this, we have that, but you're actually just shooting in the dark and something light comes up and you hit it and then you're great. Yes, that's what it is. So there is a lot to study yet. So we talked about this, we talked about STOPA already. STOPA, I didn't mention STOPA is a trial which we were part of, and that's the largest randomized control trial yet. And that actually showed, if anything, steroids might give you a short-term benefit, but it might not increase your 1-year survival rate. But there are studies in Asia which have tweaked that and used it differently, and they've had better success. But nobody, I do not know who said that, but a very famous scientist said once that nobody should die without steroids. In any case, anything, nobody should ever die without taking steroids. So if you don't know the patient is going to die, just stick him on some steroids. So we often do that in liver disease because we don't know what else to do, and they are going down the drain anyway. So might as well just help them by giving 40 milligrams of prednisolone and suppress their body's immunity totally for a fungal infection or a bacterial infection to say cost hack, treat him with tazocin for a few days and then let him go. So, but yeah, steroids have been time tested and time trusted to save people's lives. But the only thing is we do not know who are the ones they are. So they will give it to everybody and then kill half of them. So supportive treatment, again, we talked about that. So we talked about dyslipidemia, we talked about fluid replacement, we talked about hypoglycemia. And most importantly, if somebody is in liver failure, try and look for in your EPMA a very simple thing like cyclizine PRN can push them into encephalopathy. So there was a patient of mine who's still there. I mean, he's palliative now, but it took him 6 months. We kept treating him with rifaximin and all sorts of things. And he was actually using cyclizine. We stopped the cyclizine, then encephalopathy went away completely. And he was labeled as chronic portosystemic encephalopathy. And he was having this treatment for about 4 months. And he came off the rifaximin within 3-4 days. And he became not encephalopathic in 3-4 days. And then he eventually came off the rifaximin. So it is important that any centrally acting medication, so cyclizine, metoclopramide, mirtazapine, antihistamine, whatever, that might actually cause you drowsiness, that might actually act your central nervous system, stop and look for alternatives. So give them ondansetron instead, give them domperidone instead. So always be wary of opiates, codeine, and all of those things. and particularly benzodiazepines, because that's what will push them into encaphalopathy. Okay, and also beware of other complications, including of alcohol, including Wernicke's, Korsakoff's, which can kind of sway you from thinking about them and talking about encephalopathy in somebody who's got jaundice, and somebody might have a subdural hemorrhage, and you would be treating them with anti-encephalopathy measures. So always beware of those things. So we go from alcoholic liver disease to alcohol dependence now. So you use that all the time, the CIVA AR score, the Central Institute of Withdrawal Assessment, modified for alcohol, and you know that somebody hitting 9, you need to start treating them with chloride oxide, and always do them when you see them first on MEAU, but always keep a watch out that they can actually get worse. So if somebody scores 7, just don't leave them, just go after them and then make sure that they are okay. And the tool that we actually use for alcohol use disorder is the audit tool. That's the alcohol use disorder identification tool. And it has got 10 questions, but the first 3 are the ones that you are expected to check in anyone, even somebody who's coming for an outpatient visit or going to the GP. The first 3 questions will ask you about consumption. The next 4 questions will ask you about dependence. And the last questions will ask you about what's the impact it's causing. So it's structured very well. And it's an age-old tool, which we still use. And if you have somebody who's actually scoring 4 or something in your audit C, that is the consumption, with the first 3 questions, they need a brief intervention, they need some counseling, they need to do something about that. And if you do a total score of somebody 7, again, the same thing. But if you have a total score and somebody scores 20, they should be coming in for inpatient detox. And this is, even if they don't have any liver disease, you just need to make sure. So that's the audit tool. Just go through that. The first 3 questions is all you need. And that's easy to remember. Just, get acquainted to that. And it is something that you can do anywhere, even with your family, when you're actually having Christmas dinner and you're talking to your uncle later on in the afternoon. You can use the audit tool and find out what's going on there. So our patient made a spectacular recovery and went home. So this is the sad thing about it. 70% will have recalcitrant ethanol intake. And our alcohol liaison has been abysmal because the community partnership trust pulled the service. But we have some patchy cover in the hospital with the substance misuse partners who come in and kind of touch base with them so that they can contact them elsewhere. But this is something that we as a country, or even the whole world, lack a lot. Because we know that dependence of anything is actually a disease. Just because we do not know, we cannot just say addiction is psychological or, it's not mendable or it's not treatable. It's just that we don't know, we don't have the resource, and we would probably spending more resource without knowing much about it. So we don't do that, and we have other things to worry about, which we still are grappling and struggling with. And that is why it is lacking. And that is one of the main, from a clinician's point of view, from a healthcare professional's point of view, that is where we can intervene. We can't influence the laws and legislations, and that has to come from the government. We can't influence the pricing directly. The decision making is somebody else. But in the hospital, the 2 things, again, if you want to take home, 2 things, just get in touch with them, because no patient is sick. You can't refer them. They'll have to self-refer. And you know that 70% are going to be recalcitrant, 90% is not going to make that phone call. So get them an intro, most of them will already be known to them. That's number 1. And anybody with any alcohol-related admissions, doesn't matter what it is, they need to have a fibrosis assessment. And you can do 2 things. One is you can actually ask for an outpatient fibroscan when they go. Doesn't matter if they are in gastro or not. Wherever you see them, just drop in that e-referral to fibroscan so that they've got that. 50% of those patients don't attend because I see the referrals, and I know 50% don't attend. So you can also do an ELF test, which you might or might not get because they are putting a clamp on the ELF test, which is enhanced liver fibrosis test, which we'll talk about in a minute. And if that is done, then at least you know that you've gone some way to find out our risk stratifying, which is what we're going to talk about next. Okay? So we talked about liver biopsy, which is steatosis. Somebody is letting people in, aren't they? On the call. Whoever is on the call should be able to do that. Because there are people still waiting to join. So we talked about the pathogenesis of alcohol-related liver disease. And if you look at the histology, so the telltale features are you'll have steatosis, you'll have ballooning degeneration of hepatocytes, and severe foamy degeneration of the hyaline, which is the Mallory's hyaline that you would see. And that sometimes differentiates it from fatty liver disease. You wouldn't have that much of the foamy degeneration of the hyaline in metabolic dysfunction associated fatty liver disease, but sometimes it is very difficult to differentiate. And most of the times, it is always the combination of the two. Because as I said, 1/3 of the population is drinking heavily, and 35% of the population are at risk for fatty liver. So there is no win, is there? So it's going to be always a mixture of the two, and it's going to be quite difficult to differentiate, even histologically. So you see the ballooning degeneration here, and then you can see the foamy, the hyaline, the Mallory's hyaline here. Okay. So we talked about FibroScan. It is just a single mode ultrasound.
Someone has raised hand.
Yes, yeah.
Aparna's raised hand.
Aparna, is it?
Sorry, sir, I just had a small question.
Yeah,
You
yeah.
said, you
Can
have to
ask
stop
any big question also.
You said you have to stop the centrally acting antiemetics, and you
Yes.
also mentioned we stop benzodiazepine as well.
Yes.
But if you just like sort of explain the question that I had, because we use benzodiazepine often to treat alcohol withdrawal, don't we?
Yes.
So I was wondering if it's long-term benzodiazepine usage that we're concerned
No.
about.
It is any drug that you use in hospital. So that is why when I do not know if you joined the call then, I said sometimes it can be quite difficult to differentiate between encephalopathy and withdrawal.
Right.
And the treatment that we use are counterproductive to the other.
Right.
And sometimes it is even difficult for very experienced clinicians to differentiate that.
Right.
The rule of thumb is you don't have very severe liver dysfunction. You know that patient is unlikely to get encephalopathic. So that would kind of veer you towards withdrawal. And somebody who's more agitated and aggressive is probably likely to be withdrawal. And somebody who's actually getting more and more subdued and quieter and drowsy, nodding off and flaps and all of those things will actually veer towards encephalopathy. But it is sometimes very difficult. And you will have to make an assessment of the patient, get senior help, and make sure that you're making that right decision. So what I said to stop all of those things are patients who are at risk to develop encephalopathy. So if somebody is having withdrawal seizures, don't stop them.
Right. Okay.
Okay.
Thank you.
Yeah, but it can be difficult sometimes. So this is the FibroScan device. I wish we had this equipment, but we don't. We have a portable one, which is only that size of the whole thing, because that's 3 times less expensive. But it can be carried everywhere else, and it gives you exactly the same thing as it is. But you can't actually store it electronically. You can't have a server. You cannot just ping off the results to GPs. You cannot do all of those with that, but it still does the job. The patient gets a scan. The patient gets a reading. Somebody gets to see it. That's all we need. Well, we need this also, but we don't get it. But anyway, so it basically flicks you a little wave. And so that kind of shear wave, trigger wave, it just goes across the liver. And because of the stiffness of the liver, whenever it goes, it comes back. And it has a receiver that picks it up. So all it does is it actually calculates the stiffness of the liver. So the stiffer the liver, the raise the reading is. And it uses a Young's module, a fancy equation, with the liver density being constant. And you basically measure what the stiffness is. Okay, so that is a surrogate marker for scarring of the liver. And the important thing is, it's about 100 times bigger than a sample of a liver biopsy. Because the distance, it's actually got 1 centimeter wide and 4 centimeter long. It measures that part of the liver, and it is non-invasive. But it doesn't tell you anything more than a different probe will give you fat also. So apart from fat and the stiffness, it doesn't tell you anything else. So it might not be accurate in telling us the etiology. It won't give us how much inflammation is there, how much this, that, we won't get. But all you need to know is if this patient has got a stiff liver or not, and then you can work out everything else after that. The patient does not have a stiff liver, good, then you just recheck it in a few years' time. Okay, that is for fatty liver, that's for viral hepatitis, that's for alcohol, that's for autoimmune liver disease, for anything, you could use that. Okay, the one thing is that when the patient is full of alcohol, the liver is stiff anyway. So if you've been on a night out the night before, 4 o'clock, and then 9 o'clock you have your FibroScan appointment, you're going to have a stiff liver. So immediate alcohol intake, and also if the liver is very inflamed with an ALT of 400, 500, your liver is going to be stiff anyway. Or if you have heart failure, you have congestion of the liver, so you need to choose your patients and choose the time that you want to do it. That's why we do it as an outpatient. But they can go home and drink. So, but that's all you can do. But and you do tell them that they need to be stopping drinking for 1 day, 2 days, something like that. And this is how it actually measures. And literally takes 3-4 minutes to do that. And we can actually do it in bus stops, we can do it in pharmacies, we can do it anywhere. And that's what we are doing right now in the liver surveillance program, is identify those patients out on the street, because 1 in 20 walking on the street will have an abnormal liver test. So you just go around, you are actually going to pick up a few advanced fibrosis patients. And that is the drive that's going on. And none of the commissioners are interested. I was in a meeting on Friday, and they're not interested. But we cannot employ this many people to do that. That's many people, we cannot. And then stick them all on surveillance program for HCC, having 6-monthly ultrasounds and AFP. They're not interested because they have other things to deal with.
So it costs a lot of money. It will cost a lot of money to NHS.
Of course it is. Yes, of course it is. And actually, most of the commissioners will say, well, I'm not seeing patients with liver disease dropping down dead in front of me all the time. But I'm doing that with patients who have cancer and patients who have heart disease. So the liver is never going to come up the chart. How many number of graphs we show them. And I've been trying to do that for the last 15 years. No, that hasn't changed. But we are trying. So some of the other non-invasive markers that you need to be aware of, apart from the FibroScan, is a simple tool called FIB4 score. You can't use that in alcohol-related liver disease. That's one of your take-home messages, because the AST is always going to be high in alcohol-related liver disease. Even if they don't have alcoholic hepatitis, the AST is always going to be high. And FIB4 uses ALT as a numerator, and AST as the numerator, and ALT as the denominator. So the AST is always going to be high. So your FIB4 is always going to be high. So that's not useful in alcohol. So alcohol, you either do ELF or you refer for a FibroScan. In all other liver diseases, fatty liver, for the commonest liver disease, you can do a FIB4 score. And you have a cutoff value based on platelet, your age, AST and ALT, simple tool. You can calculate it yourself. You don't cost extra money to the lab, so they don't moan. They do it. Sometimes they moan because you're asking for the AST too many times. They don't do that now in our lab. But you just say FIB4 score. You can request that FIB4 score. It's on the web, drop down, and then they will do it. So once you do it, that is the most validated score. And you have other scores like the NAFLD score, the APRI, the AST-ALT ratio, and there are numerous scores at various degrees of validation. So simple tools that you can do. And once you've got that done, the second line would be your ELF or elastography or MR elastography, which we don't have. So all of those things can actually do non-invasively. And if you do have discrepancy, which you will have in all of these tests, then you can actually do a liver biopsy. Okay. So let's skip this and come to the second case. So a 48-year-old excess 70 to 80 units of alcohol for the last 10 years. So you know where that is going. So she comes in with abdominal distension, itching, high colored urine, confusion, and she has a large ascites. She's dry, she's got pedal edema, she's got sarcopenia. She doesn't have flaps. She's got peritonidomegaly, she's got spiders, she's got hepatosplenomegaly, she's got gynecomastia. She's got the full house. Okay, so what is it then? So what do you think we're looking at here?
Seems like just having decompensated chronic disease from the features that you're saying.
Yeah, so why do you say that's decompensated? That's number one.
She's confused.
Okay, that's one.
Hepatic encephalopathy.
Yeah.
She has ascites as
True.
well. Bilirubin responded.
Yeah. Okay, so she's got 3 of the 5 features that we're going to look at in our risk stratification scores. Yeah, and what is her albumin doing? 20. Okay, and what's INR doing? Well, it's not here, so it probably is going to be raised. So again, she's got full house in the child score. Okay, so that's why she's decompensated. Look at the AST and ALT here. So you don't see much of an impressive rise. And with a history, so this is not acute ALCAT. So you're not going to rush in with steroids in her case, but you know she's decompensated. Okay, so you're right. So there is a slight difference in the pathogenic mechanism in this happening as opposed to the acute ALCAT. All the acute cytokines probably was not the case in her case or his case. What has happened is the stellate stimulation, the collagen synthesis, and the cytokines do that too. So they gradually start developing more and more and more fibrosis, which then replaces the liver architecture with just scarring and nodules. Okay, so that's what happens. But again, it is cytokine induced. Okay, and then the stimulation of stellate cells and collagen synthesis. Okay, so for us to know, we say about decompensated and compensated. I'll tell you why that is important, but there are various stages even in that. So if you have a compensated cirrhosis, with the non-invasive test that we have, with the fibroscans we have, we can actually say what stage are they. Again, not validated that much. We are only learning about it a bit more and more now. So if somebody's fibroscan is less than 15 and their platelet count is more than 150, all I'm interested to know is their liver synthetic function is 1 and their portal hypertension is the other. The fibroscan is not going to give you information about liver synthetic function. That the blood test will tell you. And portal hypertension precedes liver synthetic dysfunction. Because the liver gets stiff, the blood gets stagnated. The liver cells are still functioning, so your bilirubin, clotting, albumin will not go down yet. But you should be able to pick up a hard, board-like liver before that happens. So a fibroscan of more than 15 and a platelet count of less than 150, you know they have clinically significant portal hypertension. So forget about compensated, decompensated, all of that. It's now called ACALD. So basically the patient has got active chronic, advanced chronic liver disease. Okay. So in advanced chronic liver disease, you have clinically significant portal hypertension, then you have a potential to develop varices. So that is the next stage. And then you decompensate with the varices, that's the next stage. But if you have a decompensation with not varices, but with ascites, that is the next stage. And then after that, you have a second decompensation. So with each of those stages, your life expectancy reduces. And in between, if you get a complication in some form of spontaneous bacterial peritonitis or hepatorenal syndrome or something like that, your mortality rates jumps by 20% in each stage. Okay. So for you to know and take home, somebody who's compensated is probably likely to live about 12 years. If they're lucky, they'll live for 15 years or won't require a transplant for 15 years. The moment decompensation happens, the change is 45% of them going to live 1 year. and 38% of them is going to live the second year. That's it. So decompensation is that big a difference from compensated ACLD. All right. Tells you the same thing again. So the tools that we use are the Child-Pugh score, which we talked about the 5 parameters here. You give them score of 1 to 3. And so you can score a minimum of 5 and a maximum of 15. And if you score between 5 and 6, then you are Child-Pugh A. If you actually score 7 and 9, it's Child-Pugh B. 10 to 15 is Child-Pugh C. Okay? But it does not take various other things into the equation. It only takes your albumin, your bilirubin, your encephalopathy, your ascites into the equation. It doesn't take creatinine into the equation. It doesn't take your sodium into the equation. It doesn't take your muscle mass into the equation. But it's very difficult to get all of these into one system. So you use multiple systems. So in every decompensated liver disease patient that hits your ward, you would do well because it's on the Met-Cal, on your apps. You can get all 3 scores done straight away. When you see them at admission, do one. When you discharge them, do one. And that will be very helpful for whoever is seeing them later on. Okay? Obviously, you're going to expect the first part might be much more deranged because of other factors, infections and things like that, dropping your albumin, so on and so forth. But it is something that you need to cultivate a habit if you are going to risk assess those patients properly. The MEL score uses the same thing. It uses your creatinine, it uses your albumin, your prothrombin time, and you can actually add sodium into it, the MEL sodium score, or the UKEL score, which has the sodium incorporated into it. And based on that, what you know is if your patient is Child-Pugh B, or if the UKEL score is 49 or more, or if your MEL score is 15 or more, they do poorly without a transplant. So that is the time you need to be considering to get them off to a transplant. Even simpler than that, any cirrhotic patients coming to you for the first time with ascites, you need to start thinking about transplantation. If you leave it later, you will miss the boat. Okay, but most of those patients that you would see either will come to the liver clinic or will already be under the liver clinic anyway, but you need to be starting to think in those lines. And the advice to the patients, the discussion with the patient and the family should be in those lines. So we just talked about the Child-Pugh here, and I told you the Child-Pugh score and the mortality. So the 45%, 38% is based on that. So if you have Child-Pugh C, that is, if you've developed a first ascites, you're getting a score of 7. Okay, in that case, you're not going to live, well, 45% of you will live in a year. And that can be quite a massive shock to the patients that we see and talk to them in that numbers. And from then on, their clock starts according to them. And some will take it very well, some will take it very poorly. But that is the fact. This is the MEL scoring system again. I told you about the bilirubin, creatinine, and INR with the complex formula added to with the sodium. And again, whenever you actually get the bleeding and the ascites together, that's the worst bit. Okay, so that is one varicose decompensation, one non-varicose decompensation. And that is bad news. And that's why it's bad news. In addition, you can have various other things which can cause a problem. So you can actually have rare complications like hepatopulmonary syndrome and all of those things, cardiomyopathy, cirrhotic cardiomyopathy, and things like that. But the most common is spontaneous bacterial peritonitis, which can happen even in patients walking around the road with ascites. But if you do have spontaneous bacterial peritonitis, then you have a 70% chance of it recurring, and it increases your mortality by 20%. So this is now going into the complications of cirrhosis. How do you manage variceal bleed? So you white bore cannula, you give them the fluid, you start terlipressin whether you know it's varicose or not. The patient has risk for liver disease, start them on terlipressin. That's the one thing that you can do. The patient has ascites, start them on a broad spectrum antibiotic to prevent SBP from happening. So all of those things can be done before gastro input. And I'm going to talk about the bundle, which you will all know or you would have seen. Complete that bundle in 24 hours, which will pretty much cater for all of what we are going to discuss in the next 5 minutes. Okay, so white ball cannula, you don't over-transfuse them because you increase the pressure, they bleed again. So you only need a hemoglobin between 70 and 80. And you give them terlipressin, and then you get them to an endoscopy to control the bleeding. Okay, if they are very significantly deranged in clotting, then you would require blood products and platelets, depending upon what the level is. If the platelet is low, it doesn't really matter to transfuse them platelets unless they are actively bleeding from somewhere, because platelet just gets consumed. So it's not going to stay in the system for long anyway. And you just give it, and after 6 hours, they're back to square one. Okay. If patients are not getting controlled, the GI bleed, then that is the time we consider alternate treatment modalities like putting in a stent between the hepatic vein and the portal vein called TIPS. And that kind of releases stagnation of blood. And then that decreases the blood flow, the pressure in the varices, because everything goes through the stent into the heart. And transplantation becomes a priority for these patients. Okay. So anybody hands raised? No? Okay. So ascites is the commonest. So it happens in 30% of patients with cirrhosis. And the rate at which a compensated cirrhosis becomes decompensated is about 5 to 7% a year. And if you have 30% ascites, 10% of ascites patients will get SBP. So that's 1 in 10. So you need to be thinking about everybody. And so you always do a diagnostic tab. You don't wait for anything. You don't need to check the clotting for diagnostic tab. You can do it. So do that when you get admitted rather than just sticking them on tazocin, because we do not know that they've had SBP. And somebody with SBP will have chronic secondary prophylactic antibiotics for the rest of their lives. So if you don't know and you just stuck them on tazocin or something, then you would never know. And often I see that happen on MEAU or A&E or wherever, because one, people can't be bothered to do their stick tap, or they say there is no trained expert to do that. And that is wrong. Because all of you as IMT would know how to do a paracentesis. IMT1 is okay, it's lab-based competency. But when you get to IMT3, so a medical reg, there is no way you shouldn't know an anesthetic drain. And an anesthetic tap with all the ultrasound, the portable machines and everything that you have, that's block standard. Okay. Fluid restriction has not been borne out on evidence to stop that. So this water restriction is of no use in ascites. Sodium restriction is. So normally we all take about 150 millimoles of sodium in a day, and you just restrict them to about 90. So no added extra salt. And when you're cooking, you don't do much salt in there. And that's all they need to do, along with body measurement, weight measurement every day. And the most important diuretic is spironolactone. Why is that? Yeah. So it's an aldosterone antagonist, and you do have secondary hyperaldosteronism in patients with cirrhosis developing ascites. And if you add a loop diuretic like furosemide, they work in tandem better. But obviously, you need to be mindful of the kidneys and electrolytes. And there is no point in checking the electrolytes the next day, because it will take 3 days to get rearranged unless the kidneys are precarious already. So generally, in an outpatient setting, you start them and you give them a form to have it done in a week's time. But in an inpatient setting, the next day or the day after should be okay. Do the bloods. But the weight is essential. So if after 5 consecutive days, if they have not lost more than 0.8 kilograms, then your medication is not working, the dose is not adequate, or simply your kidneys are not excreting the sodium that you wanted to excrete. So you need to change that, or what else you need to do. So in refractory patients or intractable patients who cannot tolerate a good dose of diuretic, then you do large volume paracentesis, or you consider them for TIPS or a transplant. So it's pretty much the same modalities of when you consider and what you consider for each patient. We don't put in drains willy-nilly because we burnt our fingers with that. It causes more problems. Unlike the malignant ascites, the oncologists stick in drains, which is perfectly reasonable, but not in these patients. So Fluorex drains are reserved for the terminally ill, palliative care patients or frail who cannot come to the hospital for paracentesis and things like that. So they stick them on a drain and then you manage them in the community. We've talked about SBP already. The one thing which we need to know is albumin given in SBP patients will prevent hepatorenal syndrome. So you give them 1.5 grams per kilogram body weight of albumin infusion, 20% has on day 0, and then on day 3, you give them 1 gram per kilogram body weight to them, okay? And along with antibiotics and prophylactic antibiotics for them lifelong. Very few patients need rifaximin for refractory SBP, but rifaximin is given in patients who have encephalopathy as a problem. Again, if you are having SBP, then you're at a high risk for hepatorenal. And hepatorenal is basically, you push your creatinine up in any patients with liver disease with ascites, that should be in your differential diagnosis. But often, they might be intravascularly depleted, even though they've got lots of fluid. So you need to be mindful of making them euvolemic first. There's no harm in sticking the terlipressin in, but you're never going to win if you have not filled them up. So you can give them albumin twice a day, and you can give them 1 milligram per kilogram, 1 milligram IV every 6 hours. And you can actually increase it up to 2 milligrams every 6 hours in refractory hepatorenal patients. Okay.
So the prophylactic antibiotic even after one episode of SBP?
Prophylactic, yes. Okay. In fact, you have primary prophylaxis for SBP in somebody whose total protein in the ST fluid is less than 15, okay, who has got severe hyperalbuminemia, who has got severe hyperbilirubinemia, and whose creatinine is not normed. Even if they've not had SBP, primary prophylaxis with the quinolone antibiotic is shown to reduce recurrent SBP, hepatorenal, and mortality.
When you label them as refractory ascites, how much diuretics do you give?
Yeah, so the maximum dose recommended is 160 milligrams of furosemide and 400 milligrams of spironolactone a day. And I have not seen a patient who had taken all of them or tolerated all of them. That's way too much. You would become intractable before you become refractory. So if somebody who is actually on 200 milligrams of spironolactone and 80 milligrams of furosemide, if they are not responding to me, I know they are going to be refractory. I'm not going to push them to 120 and 300 because then the kidneys will pack in. The refractory definition comes when you're not losing 0.8 grams, 0.8 kilograms of weight after 4 days of adequate antidiuretic. Intractable ones, if you're not able to tolerate any dose because of side effects, then you're intractable. But the management is the same. Hepatic encephalopathy, I think we've talked about it in detail anyway. So these are the grading of hepatic encephalopathy. You have flaps, then you know that's grade 2. If you're completely knocked off, you know you're grade 4. So the rest of the grading you can just figure out in between them. And that's easier to remember. We talked about the precipitants, particularly substance centrally acting ones, and also any infection, simple things as constipation, hyponatremia, hypokalemia, and all of those things. You need to look out for correct, and they can be simply done. It's just that we need to look and keep a watch on them. So why is lactulose more effective than anything else? And that's because lactulose is an acid. So it basically generally tends to convert your ammonia into ammonium. That's less toxic. Lactulose is a complex carbohydrate. So it actually attracts bacteria to work on that rather than the blood to split the urea and then produce the ammonia. And it's a laxative. So those are the reason why lactulose is better than Movicol or Senna or any other laxative you have in a package. And when it's combined with rifaximin, it works even better. So rifaximin is a non-absorbable antibiotic treatment because your whole gut biome has dysbiosis in liver disease. And you are trying to change it to something that will work for your advantage. And rifaximin is one of the antibiotics that worked. And that's it. And we don't know any more than that. Neomycin has been used when I was training to become a gastroenterologist. I was starting to train, and then pretty quickly we knew that the kidneys were not tolerating it very well. And also, Clostridial diphtheria is not easy to control. And then rifaximin came on. Vancomycin and all sorts of things. As far as hospital admissions are concerned and intensive care is concerned, not much ground has been made in these patients, and that's why your intensivists are not very keen in taking them, because they will often not wake up at all, because their liver synthetic function is quite down, and they might be quite significantly portal hypertensive with shunts and stuff like that. So they might not be very keen unless you have an exit strategy for them. Okay. Other agents, all of these have been around for a long, long time. Branched chain amino acids. A company has made a living using a medication called Hepamers, which is basically branched chain amino acids, and they've done numerous studies in interfering with the urea cycle and changing things around, but never have been a game changer. So we still are looking for a transplant in patients who are having recurrent or chronic portosystemic encephalopathy. The one thing you don't do in those patients is to put a TIPS in them, because then you're going to finish them off. Because a TIPS is a shunt. So you're basically taking all of the toxic blood from the gut straight into the brain, and the next morning the patient will be in grade 4 and dead. And also patients with heart failure, you don't put a TIPS in, because you're just going to flood your heart and they're going to die. So those are the kind of considerations for patient selection. So this is your decompensated bundle, which is very comprehensive, very precise, and this should be completed within 24 hours, wherever you see the patient. And so they basically have to have lifelong abstinence. If it is alcohol-related liver disease, you needed to have gotten rid of the Hep B or Hep C. If they are viral hepatitis, the rifaximin usually is lifelong or until they get the transplant. And other than that, you are basically going to keep a close watch on them and get them onto a transplant list. I'll skip this. So our patient had kind of 2 weeks of treatment. She had refractory varices, ascites. So the patient had to have a TIPS. But after that, the patient never looked back. So the patient still comes to the clinic, never been on a transplant list, because that TIPS was inserted as a bridge to a transplant. But the recompensation of the liver happened so very well that the patient never required transplant 8 years on. So there are a lot of patients like that. So you need to just give them a chance sometime. So your take-home messages in decompensated cirrhosis is always look out for an acute factor, risk stratify them when they come in and when they go out. And also, the reversible precipitating factors, and think of referring to a transplant unit early. So these are some of the things that you can actually read about to get a bit more. So we started a little bit late, isn't it? So we have another 45 minutes for the second part. Do you want to actually go and get a drink or something, or do you want to just crack on? You want a 5-minute convenience break?
We can have 5 minutes and then we can carry on.
Okay. And anybody else have any particular or strong opinions on the call? Well, they can't go anyway, can't they?